From when was he scheduled as a speaker, I said. This is just simple dialogue you have with people, when you're visiting, and all of a sudden the whole system is naked in front. The king is naked, this room is full of people, little children screaming and all, right, and there's no water fountains nearby. They want Dr. Pepper in a southern place, and there's no Dr. Pepper because they only have Coke. I mean, it's all the little things that might matter if somebody was sensitive, that they wanted Dr. Pepper. Why not put that in the damn machine, You can just hear them. They're griping. Not even any Dr. Pepper, 10, 2, and 4. You're in Arkansas, if Dr. Pepper sells more than Coke, but not the administrator. He's from San Francisco. Who the hell ever heard of Dr. Pepper, right? Everything is that way, as far as I'm concerned.
I'll say one thing. I think one of the reasons that they schedule, I'm not saying that it's right,
Yeah.
so many people at one time is because the clinics have a higher rate of no-shows than the private physicians. And there are days when you might have 8 people scheduled for 8 o'clock, although at Wake they do tend to scare stuff them a little more, and only have 1 or 2 show up, and it does happen. So to protect themselves,
Okay.
they kind of mask.
Okay. I think your point is well taken. I guess the purpose of saying it is, I'll again come back to my question. Should there be some special characteristics? Who should the person in charge? What sort of features might Ms. McGallis, what might be desirable besides being cost conscious, being all the things administrator ought to be? What additional factors might you look to, since they're the tail end of the dog in a place like this? If somebody was in charge, what would you think if you were the administrator of the whole Memorial Hospital? What kind of person would you want to run the ambulatory things?
Someone with experience in it.
Experience, okay.
To know all the problems and all the advantages.
All right.
Someone who was cost conscious. Someone who was involved in the community, I would think, since most of the people
Now, why would you care about whether they were involved in the community?
to add the humanitarian factor that seems to be lacking.
Okay.
If you know the people you serve, you can serve them better.
Okay. In all administration, when you get into it, you're going to discover there's a thing like Noah's Ark was just described as a category that I would call take a walk. There are some administrators that have never taken a walk. Are you aware of that? They are appointed, say, 22 years ago, and they've never been out of their office except to greet the president when he came to the front door, or to, visit at the university president's office or something like that. I think that American industrial management is in this trouble too, deep, deep trouble, not just with Japan and German auto competition. I think it's this total alienation from where real people are. You see, they don't know to get out. The way you spend so much time prisoner, you're a prisoner of your office. You're not careful. Only by taking a walk do you learn that, what in the world is going on here? I mean, this room's overflowing, that one's empty. Or these girls all continue to read their Gothic while the patient is talking to them, and in the next place they really care about them, and you don't do anything about those differences, in supervisors or in people or in anything. You were going to say something.
It's always been my impression that a lot of the problems that we find in clinics and hospitals and places like that is because we're educating physicians or nurses and whatever to be concerned about human beings and human life and human comfort generally. But when we look at hospitals and clinics and so forth, we are looking at them in a different light. I mean, when you say hospital, the utmost thing is profit. The utmost thing is the fact that it runs efficiently and that it runs in a making mode, whereas you set in these hospitals tons and tons of people who are supposed to be geared totally toward humans. And I think there are two different models going on. There are two different kinds of operations going on, and they're conflicting.
There's certainly a potential conflict. Would we all agree with that? How do you blend that? I mean, does anyone quarrel with Ms. Callis? You're going to bankrupt if you don't have some of the qualities Ms. McAllister named. Any question? I mean, the more experience, the more, I mean, those are features. Even if you're going to argue with the administrator, you got to know your costs, right? That, hey, we've kept our costs under control. Your hospital's what's running away with your costs. I've said that in these meetings, So, you see what I mean? You still got to know your ABCs to make an argument, right? But how do you deal with the issue Ms. Harris has raised? There is a potential conflict, isn't there? I would throw in one more thing. I've never found there anything wrong beyond being interested in the community for an administrator at any level to think of himself as a patient advocate in health care. That the doctors, let me put it in its worst form, I don't think it's necessary to hire one. Maybe it is in bigger places, keep a staff of them around or one of them. I think that the anger ought to come from the very top and be known at the reception desk and everywhere. The only way you see it, when I enter an institution, I can tell whether the top guy or the top gal cares. I mean, it's the way they jump to deal with people, It's the way they respond, There's the top person care. It's pretty evident as a disease, you follow me, that if they defend patients, if they try to get them in earlier, if they're willing to argue with doctors and get defended for doing that, there's one tone. If the professionalism, putting it in its worst meaning, not its good meaning, okay? The protection of professionals and their professionalism and their, teaching and all that comes before it all from administration, then I think you will see some of these evidences, that are on the ugly side. Well, let's have some debate. Ms. Cohen?
Debate over...
Oh, if you want to debate, it's up to you. Yeah, you can say I go much further than that if you care to.
Well,
No, I was just stating a thesis to see if it had any feeling. Do you feel, in what little contact you've had anywhere, that you can detect, even in a store, I mean, a lackadaisical clerk attitude is usually not just, I hardly ever blame the clerk or the waitress. It's somewhere the place or the shift management or something is at stake, But I don't know whether you agree.
I agree with that at times. One thing I did want to bring up, though, is that I think that sometimes outpatient facilities and clinics and health department kind of settings can be a lot more personalized than the middle upper class suspects. I think we have society can have a real middle class kind of view that clinics are for poor people, and that those aren't the kind of places that a lot of us go. And I think that if that view could start to change some, that would help the situation a lot. I think there's a real stereotype.
Well, Miss Adams may want to elaborate. She made a point, and she might have ideas as to, if you think there's been progress, in what ways you would go further.
Okay, I was just thinking, again, I'm talking primarily about weight because that's where I've been recently, as Cheryl has been. But the patients, as she mentioned, aren't rushed through. A lot of time is taken with them. There's a lot of time, too, spent, maybe because it is a teaching place, but the residents are encouraged to compare prices of medicines that they're ordering. For example, they'll go and call the pharmacy and say, how much is this medicine and how much is this medicine, so that they spend the least amount on medicines. And
Excuse me, are these family practice residents, or what kind? Internal medicine generally?
they're all, because
They're all.
they don't have to rotate.
What infects them with that? I was just wondering whether it's some program here.
Well, it's a family practice person who is the attending,
All right.
or an internal medicine person who's the
Okay.
And, you know, they don't order lab studies unless it's absolutely necessary. I mean, this is really stressed that, you know, because of the high cost and that sort of thing. There's a lot of attention paid to, is it really necessary for this patient to come back in 1 month? You know, what is the cost here? And even though the patient's there's a huge bill for a visit because it's an expensive clinic, but they really aren't pushed to pay. But still, if it's going to be a $30 cost to come back in a month, just for some reassurance and some about her health or about her teaching, you know, maybe that can be done with a phone call rather than having to come back in and ride a bus for, you know, 10 miles to get here and that sort of thing. So I think that kind of thing is being stressed. And for the second year in a row, Wake Medical Center has operated in the black, even though it's a county hospital. So that kind of attitude and losing money in the outpatient department is not causing the hospital any trouble right now.
Why, if you had to account for it administratively, why do you think? They're willing to lose money there because it ends up balancing out as good inpatients, or what?
Inpatient.
It results in better inpatients competitively, ultimately?
Because they get to charge a lot of that, if they're working on reasonable costs. They get to charge a lot of that in their bad debts from Medicare and Medicaid. And they can, they can incorporate that into their charges.
Yeah, and we don't know their Hill-Burton thing. Unless you're part of administration, you don't know whether they need these losses to prove they're inside a good Hill-Burton percentage, you know, or something. Sometimes it is an economic motive, but you're describing some caring coming from good professionals, good human beings that are passing these traditions on.
But you all, even though you may have a setting like that, my experience over at Memorial, I guess, has been a bad one, is that, well, let me give you an example. I went for a general physical and they found something on my cornea and they said, well, okay, let's get you into our ophthalmology and see what's there. And I said, well, fine. And I go over and no one knows who I am once I leave family practice clinic. And I get these 3 people coming in, you know, typical setting. There are 3 bodies that I know nothing about, and everybody pokes in my eye. And then they sling around some words that I've never heard of before, supposedly. And then they proceed to discuss me and potential reasons for my problems. And the only thing that I was asked was, well, have you had any recent injuries? And I said, no recent ones, and proceed to try to tell them about some past ones, and I was cut off. Now, that to me would have been very, very intimidating to a lot of the patients my students have to take care of. They would have frozen. They would have never said, well, hey, wait a minute, let me tell you what happened 10 years ago, and maybe this is scar tissue from this. Or explain to me all the stuff you're telling this, what was it, first or second year med student. And, you know, it's important to the med student, but it's not important to me. The fact that, yes, they looked and tried to find a generic drug, yes, they did try to see me timely, was totally erased by what went on during the visit.
That was a good example, yeah.
I just can't see, knowing the workings of Wake Medical, kind of pretty closely there, I can't stress enough how much I think AHAC has to do with that. Because I just can't think that those, I mean, the administration knows that something can be tightened up there, but they're losing money. And although I think their administration is a little bit of dead wood, they've got some old guys up there that they're going to be kicked out for a while, or kicked over one. I think they're going to, I think they're going to get a much tighter administration, but that AHAC is the one that keeps that thing operating like it is. And these large inner city hospitals, like up north and stuff, they're just dying. I don't think you're going to find improving conditions.
And let me ask a question first. Is everybody here aware of the term that was just used, AHEC? All right, you want to, Ms. Young, can you explain it? You know the initials?
Allied Health Education.
Area Health Education
So, and it's a network
Center,
in the
yeah.
university system. transport.
Yeah, and North Carolina happens to have one of the outstanding AHEC systems in the nation. You know, so there is funding. I mean, that's the important thing in Greensboro and Raleigh and the cities where it exists, you know. Yes, Miss Proctor, had your hand up.
Ms. Harris brought up a point a while ago. I think it's going to vary depending on personal experience. I've run into, even at Wake, I think the system at Wake is a lot better, having worked with an inpatient staff, which is really lousy. But in the outpatient, I really enjoy that. And I think it is the physicians who are connected with AHEC. But the difference in kind of the socialization of nurses and doctors is something that we've kind of batted around a little bit over in the School of Nursing and nurse practitioners. And of the fact that nurse practitioners, possibly because they're newer, but they don't get sued very often at all, and neither do nurses. And speculating as to reasons why. I think.
Now I want you to follow that up. I'm not following. I'm understanding what you're saying, but what's the significance then back on the doctors?
We're talking about humanitarian. We're talking about relationships.
Okay.
That kind of thing. And I think that nurses are kind of educated in that direction.
Yeah.
That your relationship with the patient
Right.
is just, the all-important thing.
Right.
And I don't think that medicine has traditionally focused on that, although they are changing. I'm not criticizing
Yeah.
them for that. So that maybe that's not quite as important. So that there is, I find, generally when there's a nurse somewhere, and the nurse in the clinic, over at Wake, is the one who keeps things together.
So a nurse administrator of that whole session, or what?
No, she's just the supervisor of the clinic, and then there are
Okay.
a couple of nurses under her, but the patients see them every time they come, and she's
Okay.
kind of like that. Focal point, but she kind of keeps things
Yeah.
organized through all the residents and stuff like that. But I think nurses, I'm just saying that they tend to take the time to develop a relationship more because they're kind of geared that way. And there are statistics to show that nurses and nurse practitioners are sued very often
Yeah.
at all.
Yeah.
There was also something that was said too that showed that doctors who have good relationships with patients are sued. It's the ones that the patients are mad at because they haven't taken time with them or they haven't explained.
Oh, yeah,
things that are
right.
going to get
Yeah.
But, I'll say one more thing. Although I'm all for focusing on that because I think that's what's important, I think that when we go to the hospital administrators, that we can't say we need better lighting for our patients or we need more staff because we don't want them to have to wait so long. I think that we have to focus on costs and we have to focus on very hard list of facts. I don't think this works.
Right.
I mean,
Huh?
to say that.
Well, let's talk about malpractice a minute. What does the typical doctor do when a lot of them now have a fear of malpractice? What's the single most common thing that tends to cause them to do?
Order more diagnostics.
Yeah, it is not to improve their relations with patients. Generally, the studies have shown there's only one single denominator, and that is, if you were ordering $150 worth of tests, you run it up to $650, and by then being able to show the court how hard you work to get a correct diagnosis. They retreat even more into their microscopic, little world of scientism, rather than realizing what, say, an administrator of a clinic, if any of you have to administer, the first thing you do when a patient is terribly angry or threatening is there's several simple rules I've always followed, or no other administrators have followed. First, if they've hurt themselves in the clinic, you charge them nothing. You don't ever worry about what a lawyer says or a doctor says. The first thing is they've fallen down, claim they've fallen down. In your fish pond or between your chairs or anything else they've claimed, okay, is you charge them nothing. You take them right to X-ray and you charge them nothing. Anything to reassure them, and the administrator gets into it as personally as he wants to. If I'm shown the whole place loves them, okay? Point one. Point two, that's general liability insurance, okay? point two with malpractice, it's to function as an administrator exactly the opposite if necessary. In other words, to never concede anything. You know, you're backing a lawyer that's going to ultimately be in it for the carrier or somebody. So you're not agreeing, but you're listening. You be a tremendous listener. The doctor may not have been a good listener. All the guy may want to do is tell you what a dirty that guy was in post-op care. You know what I mean? I told him it was hurting, and he didn't listen to me. I told him when he pulled the bandage off of her. You see what I mean? And Jesus, I hate that, Mr. So-and-so. You know, and you give him human sympathy at great length, and it may lead to nothing. But all these are more important than anything the doctor, imagines is going on. A patient. The third thing, of course, is billing. Usually, if you continue to send a bill to a person who's been hurt out, well, why not just tell the business to lose that bill? Don't put it into the 30-day cycle for a while, Maybe we'll ultimately do it, maybe we won't. But, lawyers tend to give you, hey, that could be interpreted this way, or it could be interpreted that way. That's not as nearly as important as what experience will tell you. That getting that bill after having has undone everything you've done for me. Why, I told him he was no damn good. Now here's a bill that I owe him, a back balance of $138.20 more for that visit that I said he hurt me on, let's just lose the bill for a while and see if you get a malpractice case. What are we talking about? Human. It's what what are the qualities you've got to have? If you're cost conscious at that point, premium's going to go up. If you want to be cost conscious, you're going to get bigger, much bigger stuff. Yeah. Yeah, right. Exactly right. The other thing, just to finish off a little bit of malpractice nitty-gritty is, it's amazing that even the most money-hungry lawyer, or a percentage, one who's working on a contingency fee, who has the most drive to get something out of you, if you talk to your doctor, you pretty much share what's going to get disclosed anyway very early before he goes to discovery of something wrong. And sometimes we're sitting down around the table and showing him where it came from. We're like, let him see it. If you talk to the doctor at this time, it's going to look very calm and the witness stand. It's very careful on to list all the things that went through his mind. You sometimes find they look at their face and say they are just things. So it's like, wait, it's worth the time in the end. But mostly we're talking about human characteristics, and I've never found that if you have those qualities, contradictions in him, that's what you hear them, that's what often, all that, add the other to it. If it's true in all things, if I mentioned should have found it. Labor relations. Who's the most sensitive person? Nobody but the average there. Within the corporate structure that is not that. They raise things back, you don't know it, all kind of issues, but they force them down to the structure. So the human, this I can't emphasize. Human, the direction, manliness to it down, understanding whether it's understanding why they're found in the road. Try to understand their point of view. If you don't begin with that, trouble. It may look like it's straight. It looks like it is. In fact, see it over. One more multiplier, and I'm done. When a complaint is you as a consumer, I have a witness and I get a multiplier of 2. I said, how about that? I probably heard something. It's a crazy figure, but in my mind, a complaint, the person who was there to get through, and you, the deal, that
companies are most of the time they're trying to hit on but I mean, when they're not that set. So out of the area they're in, and even another floor, you know, but waiting in the office, while the upstairs open, you know, that's, you put them down for crazy if you want to, and then people would run back. That's great. If we saw the thing, but keep your eye on that. We've got enough more people, and maybe under the party does, maybe the nurses, and, you know, keep your eye on those. And then it's time to put that in. We don't get through our, you know, you'll see a reason for it, we'll cover the first sentence, okay? We didn't get through sufficient mix, but I'm not too worried that we can get through practice the first sentence later on. Well, produced by who? Thank you. Okay. Thank you again for your time. I've given you a good bit of reading, but I hope you can get through them because we got this person.